well. We'll do introductions here in a second. Because of how the webinar works, we won't be able to do introductions on the phone, but we do welcome you. I understand how difficult it is to get schedules to work, and that all of you were willing to take time to participate in this conversation with us, not only today, but over the next few months. We really appreciate. And we're really sensitive to how demanding your schedules are, and understand what it means for you to take the time to be able to join us. So we really do appreciate that. As we talk about the process we're going to use, we'll describe a little bit how we tried to organize this in a way that hopefully makes it as convenient for you as possible, although we're very glad to talk about process as we go along to make sure we get it just right for everyone. My name is Greg Moody. I'm the Director of the Governor's Office of Health Transformation. Let's do a round of introductions, and then we'll jump right in.
Good afternoon. I'm Mary Applegate. I'm the Medical Director for Medicaid.
John McCarthy, Director of the Department of Medicaid.
Cindy Markman with Medicaid.
Josh Alpacorn with McKinsey.
Bob Robinson, Lead Medical Director for Moline Healthcare.
Rob Snyder with Nationwide Children's and Pediatrics.
Shelley Dina, pediatrician from Cleveland Clinic.
Alan Ford, I'm a family doc from Cleveland Clinic and Better Health Greater Cleveland.
Eric Drobny, Emergency Medicine with Mount Carmel Health.
Don Morton with CareSource. Larry Blomster, I'm the Outpatient Medical Director for Central Ohio Primary Care.
Dave Applegate with Ohio Health.
Richardson, Ohio Health.
Karen Hoyt, Medicaid.
Brian Batchelder, Akron General Hospital, past president of the OEFP and president-elect of the OSMA.
Srinivas Murugly, United Healthcare.
Brad Lucas, Chief Medical Officer with Buckeye Health Plan.
Linda Post, Chief Medical Officer for United Healthcare Community Plan. I'm Diane LeMay. I'm Medical Director for Anthem for Ohio. Cindy Deep with Anthem. Christina Haggerty, Network Director with Anthem. Abby Sindra-Murthy, I'm an internist with University Hospital.
Shay O'Mara, I'm the Trauma Medical Director at Grant Medical Center, Ohio Health.
Joseph Farah, I'm General Surgeon in Toledo, and I'm Vice President of Surgical Services at ProMedica Toledo Hospital.
Lisa Benton, General Surgeon, Medical Director at Aetna.
Cara Carter from McKinsey. Monica Yinger, Office of Health Transformation. Teresa Hatton with the Office of Health Transformation.
And back, Tom.
Tom Baker with OSMA.
Jen Johns, Cleveland Clinic.
Mark Rizzuti, Medicaid.
Rosanna Henderson, Medicaid. I'm Kevin about Medicaid.
Andrew Stidham, Medicaid. Mary Beth Cannon, Medicaid. Nancy Borlato, Medicaid.
And Mike Potter. Great. Okay. Hopefully most of you are familiar with the Governor's Office of Health Transformation. When he came into office 4 years ago, he had this insight that a lot of what seemed to be going wrong for the state health-related services was just their disconnected nature. Things organized in departments that were separated and not always working well together. Not unlike a lot of the challenges that you all face as you're trying to coordinate and bring together health services. Health transformation was designed to take the strategic planning and budgeting of all of the state's healthcare-related agencies and bring them together to coordinate better. And as we did that, focusing first on Medicaid and some of our infrastructure issues, as we got a better handle on coordinating ourselves, we realized we had an opportunity to partner with commercial insurance plans, businesses, provider systems outside of just the public programs to align on some common objectives, particularly around rewarding value. And this idea that a lot about how we pay sometimes is rewarding volume instead of value. And is there a way to start moving in the value direction? We'll cover some of the background on that. But where we ended up was about 18 months ago, we aligned on an idea for an episode-based payment design, a general model that we thought could be applied to specific episodes in a way that would create a real financial incentive for doing the right thing, what folks are wanting to do anyway, but to really attach a financial incentive to creating value in those episodes. We identified a group of episodes we launched, and now we're wanting to work on a second group of episodes. And we thought before we jumped right into the clinical design decisions related to what those episodes might look like, we would first kind of walk through some of the experience we've had in Wave 1, talk a little bit about how the model works so you all can get essentially up to speed on some of the work over the past 18 months. We can address any general questions, everybody together, and then from this point forward, we'll be in smaller, more focused clinical advisory teams focused on very specific episodes. So that's the idea. So this is the kind of level setting. Any question is a good question. Some of you could give this presentation yourselves because you participated in this already. For some of you, it might be brand new. So we want to make sure that everybody can leave today with the shared understanding. Any questions as we get started? Okay, let's just jump right into kind of an overview of where we've been, and then please just catch my attention as we go along. We'll answer questions along the way, and there are a few spots we'll stop to have a discussion. Okay. So this is our starting point. What are these clinical advisory groups? We made a very good decision in our first round of episodes where we asked the financial folks to essentially leave the room because we didn't want to be led down a path where the way we pay ended up being kind of the design of how to practice medicine. We instead wanted clinical folks to say, look, if you can separate the payment from what you do, what would be an ideal patient journey through a particular episode? And then ask the question, do we pay you to do that? Or do you do that despite sometimes the wrong incentives from the financial side? So the idea is that this is a clinical focus to identify an ideal patient journey, and then later we will match up the payment. The groups we've identified build on the first wave of episodes that are currently in play. Anthem, Aetna, Medical Mutual, United, and the 5 Medicaid managed care plans in March all started sending performance reports to providers who do perinatal, asthma acute exacerbation, COPD acute exacerbation, total joint replacement, and both acute and non-acute PCI. That was our first wave of episodes. What we're now looking at is designing a second wave of episodes to bring online for performance reporting beginning in January 2016, with the ultimate goal of attaching payment rewards where folks are already generating value. So that list of Wave 2 episodes is upper respiratory, urinary tract infection. You can see the list there. We tried to organize these. The last time we had a specific clinical team for every episode. So we had a whole bunch of people meeting over a long period of time. This time we selected episodes that hopefully cluster clinical expertise for the same group to design the first 2, the second 2, and the third 3 together. So we have 3 clinical advisory groups, and hopefully you can already identify which of these you're on. So from this point forward, we'll meet in these individual groups on the schedule listed here. Any question about the timing and the schedule? The idea is to be intensive over a short period of time. To hopefully hit your schedules as little as we need to. Okay. The next slide, if there's one page that kind of says where we are, this is it. I mentioned Office of Health Transformation coordinates this for the state. Paying for healthcare value instead of volume across Medicaid, state employee, commercial populations. We've had a focus on launching episode-based payments, which I already mentioned. There is a second half to this equation, though, related to enhanced primary care. And we have a second track of work that is developing a payment model to reward primary care around a patient-centered medical home model. And the idea is not that it is one or the other. It is that patient-centered medical home creates a better ability to initially provide care coordination, but then when things go wrong and an episode occurs, there's an explicit tie back to primary care in many cases. So this is not one or the other. It's that these two approaches can complement each other. And by the way, they add up into something that starts looking like an accountable care organization. We made a very specific decision early in this process that we thought where Ohio is, even though accountable care organizations may be inevitable in the future, and some of you are in organizations that are doing that now, that many providers aren't there yet. So the idea was that we work on building blocks, enhanced primary care, and value in episodes, and then you all can figure out how to start assembling that into what starts looking like an accountable care organization. So we thought it would be inappropriate for the state to referee who gets to be an ACO, but we'd like everybody to be working on some track that is moving toward value-based payments. Does that make sense as an approach? Okay. So there are the two approaches, the episode-based payments and the primary care. I mentioned the partners, Anthem, Aetna, Medical Mutual United, CareSource, Buckeye, Molina, Paramount, 5 Medicaid MCOs. In combination, if we reach with this group about 80% of Ohio's population. So there is a real critical mass here in terms of going to a meaningful scale. We're trying to build on the momentum of other policy choices we've made, like extending Medicaid coverage. We are also mindful of other complementary strategies, like an HIT strategy that enables some of the activities that are required, the kind of coordination required in a value-based arrangement. Workforce strategies, are we training toward the right teams of care, and other enabling strategies. And as I mentioned, we've been doing this for a while. We're up to a number of people who have participated in the process. Okay. So why are we doing this is really kind of the approach and how the governor thinks about it. So this is where we are for Ohio in terms of the value statement. What you're looking at, the red bar there, is our per capita spending in Ohio. We spend more on health care than all but about 17 states. And our position left to right is in terms of outcomes. We rank about 30th in terms of health outcomes. There are a lot of ways to measure this. The outcome measure is the Commonwealth Fund state scorecard on health system performance. There are others you can pick, but Ohio often is in that lower third or lower quartile in terms of health outcomes. So this is really the value statement. We pay on the high side, we get results on the low side. A lot of that, we believe, is driven by the realities of the fee-for-service system, where it's not that the healthcare market has failed, it's that the healthcare market is calibrated to reward the wrong kind of thing. Fee-for-service really rewards volume without regard to quality, or making distinctions of quality among providers. And because the different component parts are each being paid a fee, it reinforces the notion of fragmentation as opposed to collaboration. So nothing new here. Folks have kind of agreed we should abandon fee-for-service for a while. It's just as a practical matter, how do you actually start thinking that through? One of the recent catalysts to thinking this through has been a federal grant, the State Innovation Model grant process. Ohio received a $3 million grant 3 years ago to do payment innovation design work. That's what led us to the idea of enhanced primary care and episode-based payments. We then reapplied for a testing grant, and last fall were awarded $75 million to do this work. So we have resources to do the work. And in addition to the money, which is good, what it really brings is a focus and attention on Ohio, where we're a federally designated test site, which is helpful then to get all the payers, the insurance plans, focused on Ohio as a place we need to take payment innovation seriously. So this lines up pretty well for Ohio to really be a leader for the country. The next view, again, is something that is familiar to you. If we were to draw this to scale, most of the system today is fee-for-service. The little gray block there would take up the whole picture, with a little bit of population-based activity around the edges as folks are figuring their way to ACO-style contracts or some patient medical home population-based payments. But then the reality is we have a whole lot of spending in between, a few very high-cost episodes that consume a lot of the spending. So really the question is, in the future, maybe this picture is entirely a population-based payment like an ACO. It's almost entirely fee-for-service. What is the path from one to the other? The next slide is a statement of things I've mentioned already around the choices we've made for the role of the state. There, under the state's role, we are willing to take a fairly aggressive stance in requiring our own programs to go this direction. So John McCarthy is Medicaid Director through his contracts with the Medicaid Managed Care Plans, can just instruct them to adopt our episode-based models. With our commercial partners, it's a more voluntary arrangement. We say, look, we're wanting to go this way in Medicaid. Does this make sense for you? We go back and forth a little bit, but if it does, then they voluntarily adopt the model themselves. We're very careful to keep a clear proprietary distance among those partners, where Medicaid will be very forthcoming in what we intend to do, but then those other plans can make decisions as independent businesses to either adopt the approach or not. We also, in addition to Medicaid, have our own employee health system and retirement systems, all of whom have been at the table for this conversation. You can see some dates there applied to these two tracks of work. As it relates to the patient-centered medical homes, Ohio is also fortunate in Southwest Ohio to have something called the Comprehensive Primary Care Initiative. This is a federally designated site, one of 7, where multi-payers have come together to design a new financial model to reward patient-centered medical homes. They are in an experimental mode. So we're in a position to benefit from what they're learning about attribution and how you put together financial incentives, how do you handle quality measures. So then we can think about how to generalize that and take it to scale statewide. And that work will be happening on a track through this year around how to generalize CPC into a model we can roll out to other places. And then on the episode side, I've already mentioned the first 6 episodes, and now we're in this stage of the second set. And I will preview, too, that we have already thought ahead to wave 3 and identified behavioral health as an area we really want to be the focus for the next wave of episodes. Behavioral health does not have as much evidence around or experience around how to create episodes from in that area, and we didn't want to rush into that. There was a lot of interest in doing behavioral health right now, but we think we're going to need a little bit more time to work on that. So wave 2 is underway right now, and then wave 3 will start later in the summer for a January 17 launch of behavioral health episodes. Okay. So all of that is just background to get us to the real conversation today, and what is the model we're looking at. I think early in the conversation, we all had in mind some version of a thing where we would say, here's an episode, and we wanted good outcome. So in advance, here is some money for you to achieve the outcome. The idea of a prospective version where then somebody would take on accountability for providing that episode of care. And what we quickly understood was, although some organizations may be able to do that, the system isn't really designed that way. How do you divide those resources among partners? Who is accountable for what aspects of the episode? Can we get access to information about whether the episode was successful or not? So we started then thinking about, what do we have now that we can look at that lets us start to approximate the notion of what an episode would be. And the idea, and really the decision of the direction we took is on this page, where patients seek care, providers submit claims, and payers reimburse, you recognize is the way it works today. So we're really relying on the system as it is today, but then what we do is pull all of the claims related to a particular episode, look at them for a particular provider, and then make decisions about how that needs to be adjusted to be fair in getting at what performance looks like for a particular provider. If you take all of the sickest patients, you're going to be more expensive than another provider. That shouldn't count against you. We should encourage folks to take the difficult cases if they're being able to provide the highest value care. So how do we risk adjust that? How do we exclude cases that are unfair to compare? A bunch of decisions to try to make this as fair as possible. That is the work of these groups. That's the part that normally the insurance plan might risk adjust, or from the financial side, those decisions are made. We wanted to make all of those decisions based on things that could be backed up by clinical evidence. So you pull those claims, you put them together, you make those adjustments, and then you basically just share that with folks. How are you doing? You know, are you meeting quality, minimum quality criteria compared to peers? Is your price on average higher or lower than your peers? And then the final step is, and then for folks who are really generating value, a lower cost for that level of risk. Currently, that's a real bargain because you're a low price and the savings are accruing to the insurance company. Why not take some of that money and share it back with those high-value providers for doing the right thing? And then, yeah, question. Yeah.
So with the average cost, we certainly in private practice we charge a certain amount for a certain service, but then of course you have a contract with an insurance company and your reimbursement is based on that contract. So what cost are you referring to? What we're actually reimbursed, or what we charge? What you pay? Or paid. Got it. And part of that's actually going to be determined by the insurance company, correct?
Yes. So if you flip the page, what does this start to look like? And as we get into the detail of the model, there's a lot of complexity. So for example, in a joint replacement, we're holding the surgeon accountable, but they may be in a hospital that negotiated a particular DRG over which they have no control.
Right.
So who's in control of that? And then how was that negotiated with the insurance plan? So as we get into the detail, the answer is actually a lot more nuanced than I just gave you. But But in general, we're looking for the real amount. What was actually spent to provide the service. This picture then starts to show how you can start thinking of this information. And again, this is a really high level. And then what we're going to do is drill down into the detail of how this curve is constructed. But to cut to the end point, how would you start thinking of attaching payments to performance in this sort of a framework? What this is actual Medicaid fee-for-service payments that existed for a particular episode. This is not what they're aspiring to do. They're already providing these services at these prices. And it's already been risk adjusted, and complicated cases have been thrown out. So think of it as roughly routine cases being compared here. The providers on the right, on average, are providing a real value because they are providing that service at that price. And you can see if they knew what the insurance plan knew, that the insurance plan was paying in the red range, but they're paying them in the green range, that is very powerful information for that provider to be able to say, look, I'm a good value. Let's work out an arrangement where I can share in some of the value I'm providing. Now, on the other side, it sort of works the other way from the provider view. The plan, the next time that contract is up, may say, you know what, we're rethinking our network, and we're not sure anymore. Or can you get your prices kind of in a range here that look more like your peers? Or it may be that somebody is able to make the case that, no, there's something unique about my practice you need to understand that actually merits the additional cost. It at least gives folks the basis of having that conversation versus, particularly from the provider view, having no idea what the insurance company can see about you and others. So that's the idea. How does this start creating a different sort of conversation around what does value mean? Now, there's yeah, sure.
I'm just a little confused about what over time, or is this kind of what are we looking at?
Yeah. So, and again, we'll go into a lot of detail. What we're looking at here is for a particular period, for a particular episode, let's call it asthma acute exacerbation, pulling all of the claims related to that episode for individual providers. So for a hospital, where maybe there were 200 cases, and those claims were pulled, on average, after risk adjustment, what was the average cost of that episode for a particular hospital? That's what you're looking at here. And then that is shown in comparison to other providers for that episode. And then what's made up are the dotted lines. So then you can start applying some value judgment to say, well, look, within a certain commendable range, can we share back from the payer to the provider for providing that value? So in that range in green, maybe you share 50-50 those savings. On the red range, is there some acceptable limit where if you're above it, it's now viewed as unacceptable, and what does that mean? Now in the middle range, the gray, what's interesting about this particular approach is nothing happens in the gray. You were paid a fee-for-service rate, you're kind of in an average range, no harm, no foul. The idea, though, is this is not intended to be a gotcha. It's like, aha, see where you are? I'm going to come take money from you. It's intended to put this out so you can see your performance, and then the ranges are set, and then only after those are known do you then in the future start attaching payment to it. So if you're in the red range, you can get into the gray, or if you're in the gray range, you can get into the green and become eligible for gain share. There's one last detail on this particular picture, one last point I want to make. This is not about just racing to some bottom price. So there are two elements of the idea here that kind of resist just running, not doing anything. So one is this gain sharing one. On these episodes, there is some amount of resource required to properly provide the episode. So we set a floor there. You can't gain share for a price that goes below that floor because that's really undermining what it really probably takes to perform that episode. And there are quality indicators that must be met to be eligible for gain share. So for example, in this presentation, the providers in blue did not meet a minimum quality threshold, so they're ineligible for gain share. The providers in green met the minimum quality threshold, so they are eligible for gain share. And again, this is not giving or taking away anything. Folks have already been paid this. The question is, from this position that has already occurred, if you're doing a great job, is there some opportunity for gain share? Yeah.
Will there be baseline information for the group based on what Medicaid has paid out for this episode? The groups have that available to us?
Yes. So then this becomes a very data-intensive activity, particularly as it relates to the risk adjustment, because what the presence of certain risk factors is highly correlated to the price of the episode. So that's a level where you do have to get into a tremendous amount of data. And I'll get to this in a second. That's where we've asked for help to get some folks who are really experts in that area to be able to present the data to you in a way that it actually lets you make real decisions.
And there would be some kind of committee where you would present your case. This case was much more out, or are there certain...
Hold the thought, and we'll get to a process that does some of that automatically, but then if you still have the questions, let's go back to it. Yeah.
I think one of the challenges that I see is determining the acceptable and commendable threshold. I mean, these are dollar amounts. And these acceptable and commendable thresholds appear to be some value-based measurement. So, I mean, are we talking about incremental cost-effective ratios or some type of, is that what we're talking about, call-ins and these types of things, and we go in that direction? Or there has to be some way of determining those, some numerical way of assessing value.
So you're right on one of the most critical issues that we're going to insist we kind of hold for later, because we don't want to become preoccupied with kind of the money first. But you're exactly right. And there is an important element in the state's approach that this is a particularly good example of. It's this issue of what we insist on or what others voluntarily choose to do. John McCarthy, as Medicaid director, can look at this for Medicaid data and apply those lines and then say to the Medicaid managed care plans, I'm just insisting that you use these thresholds. We have not decided to do that. We may let each plan determine it separately, but we could control that. On the commercial side, that will be up to those plans with their networks to essentially have a conversation around. So, you're over here on the right-hand side in the gray, you're going to be arguing that threshold should catch you and you should be eligible for gain share. But we are not talking about a regulatory framework where we somehow prescribe that, particularly on the commercial insurance. Now, there is one way of thinking of it, too, where for the state, things like budget neutrality are important. Do you set it so there's money coming out that is equivalent to money going in? Normally, that would be the way folks would think about it, so it would be budget neutral. We don't think of it quite that way, because what we want to do is set the thresholds, and then if everybody improves into the green and everybody becomes eligible for gain sharing, well, that's great for the system, because it's at a more manageable price and you're gain sharing on the value. So we are not aiming for a target, for example, where we're either trying to save an amount of money or spend an amount of money.
So I think the quality metric does guarantee better patient care. I think there's a minimum standard that gain sharing means. I think one other thing that comes to mind with academic teaching hospitals, sicker patients, exchange of aids, patients transferred in, and you mentioned this briefly, there has to be some type of accountability for when the patient gets transferred to a tertiary center because they're sicker. They have pneumonia, but they're sicker than just a garden variety pneumonia, or they're transferred to a teaching, to a medical school, and where it costs a lot more.
Absolutely. And again, hold the thought, because you're anticipating exactly the kind of issue then that becomes central to how the model works. That's right. And I apologize for kind of reducing this to, red, grade, green. I mean, this is a very complex model, and we'll go into the details. But at least as an initial orientation, this is kind of where we're headed. At the end of the day, is there a way to kind of discern relative value? And now, the devil's in the details. So I think next, what we'll do is walk through some specific examples to show you kind of the mechanics of the model. And in the back of your mind, for the episode that you'll be working on, you can start thinking about, oh, okay, here's the parallel to that particular episode. You can start thinking ahead to the sorts of design questions that you would insist be resolved to be comfortable with something like that. Yeah.
Is the idea then for the advisory groups to come up with consensus around who's the principal accountable provider, what the risk stratification would be that would work for both Medicaid and commercial payers?
That's exactly right.
I couldn't hear her comment, so what?
No, my question was the idea behind the advisory groups and the clinical groups to come up with some sort of consensus that would actually be okay with Medicaid and with commercial payers, say around the accountable provider and whatnot.
My question was, I'm pretty sure I heard you say there's nothing taken away. So if there's nothing taken away from the reg group, what's their incentive to move down to the mean?
I didn't quite say that.
Yeah, that's what I didn't understand. Okay.
So our objective from the outset isn't necessarily, for example, to be budget neutral, or to save $100 million, or to spend $100 million. It's to identify something where there is an upside and downside risk and set those thresholds. But then if everybody can perform to get out of the red, that'd be good news. Right. Because what it would mean is the average cost has moved into a more sustainable range. So it's not as if we're going to apply a relative scale, so 25% always lose and 25% always gain. The idea is to set a target where folks can improve toward. Now, having said that, I do think, if you're a commercial plan and you now have this information, you're going to want to show it to the providers who are on the left when their network contract is coming up, and you probably don't want to share it on the right. But if you're the provider on the right, you sure want to put that in front of the plan and say, let's talk about kind of how this works exactly. Because they have this now. The plans have this. The providers don't necessarily have this view of themselves.
But they don't have the quality metrics.
Correct. Correct. Or they have a view of quality they've determined, not necessarily a view of quality that clinicians view as relevant for a particular episode. You have a star or something. Right. But we're talking about attaching quality measurement to actual patient outcome. Okay. So, and I appreciate a little kind of faith that we'll kind of get into some places where you can really ask your real questions, which is next. So the next page then repeats. We're going to basically draw this curve for these different episodes. We realized early on a couple things. in terms of crossing this line from being just public program focused into commercial, there's a whole lot that is the same, but there's a whole lot that is not the same. So we didn't really have some of the expertise we needed to be able to fluidly understand how some of this would apply across that line. And there is a real heavy lift here in terms of relying on data, not anecdotes, to kind of determine the design of a model. And you all have, I know, been involved in activities where you're either evidence-driven or they're kind of opinions that determine the result. We wanted to be real data-driven, and internally we didn't have the resources we needed. So part of the benefit of the federal grant, the original one for the design work, was it let us bring online. It ended up being McKinsey as our technical advisors, but we had a competition on that, and we picked them. You heard in the introductions a couple folks from McKinsey here. So at this point, as we have through some of this process, the state has retained its decisions, but we do look to McKinsey for some of the technical advice. So Cara, I may turn to you for more of an introduction and then a detailed discussion.
Thank you. I appreciate that. And I'm delighted to be working with all of you over the next few months as we get into this in some detail. I think we can flip to the next slide because I think we've covered what the episodes are. So just in terms of setting the stage, and Director Moody touched on some of this, I want to just highlight some of the responsibilities for these groups as we move forward over the next few months, and some of the things that we definitely will not do. So the objective, I think, Director Moody described very nicely around getting a group of folks together who are able to provide clinical input to the shape of these episodes, so we design them in a way that is appropriate and makes sense for patients in Ohio. So to do that, we're asking folks to come in person if you can, and we really appreciate your time. We understand that it's a big commitment. To actively participate in the discussion, and we will send pre-read material. So as highlighted earlier, this becomes a highly technical process. We're going to dive into a lot of data. We're going to open the black box on exactly what goes into these episodes in a level of detail around which codes are in, which codes are out, which codes are adjusted, which things count as exceptions, which things don't, which are all the questions you're asking. And it tends to be a very detailed, data-driven conversation in a way that feels a little bit different because we're going to open it all up and look at it. So we ask people to review the pre-read if you can. It makes it easier to have a conversation rather than trawling through the codes one by one in a meeting. And we ask you to have an open mind. So I love the nature of the questions that you've asked so far. They're exactly in the right direction. This is a little bit different from perhaps the way that you've approached payment or value-based payments previously, so we ask you to keep an open mind to it. Some things you'll find feel natural and like they make sense. Some things you'll hear will feel like they don't make as much sense. Bear with us as we work through an iterative process, and hopefully, over the next few months, as we get towards the end of it, we'll get to a place where everybody's mostly aligned. Just to highlight the things that we are not going to do, and I think Director Moody highlighted this already, but I'll just focus on it again. This group won't talk about payment. So I'm going to walk through 2 pages from now all of the questions that we will talk about, and there's a lot of them, so don't worry, there's plenty of material to work through. But we're not going to talk about detailed elements of pricing or use this as a contracting negotiation. We have we have clinicians from both payers and providers around this table, and that is very healthy, and it helps us get to a good clinical answer. But it's not the right place to talk about, my specific hospital and my specific contract with you as a payer. And then the gray box just is very important on this chart, just to remind folks that we're talking about, trying to line up the stars where we can, and the state with its payers spent a long time designing a charter on which things would be, different by design and which things should be aligned in principle. And so, for example, the state and payers agree that it makes sense to have quality metrics that are similar so that providers don't get confused around different quality metrics for the same thing. But each payer will set those thresholds wherever they like. And then the same kind of notion on payment, there's no intent to try to have even a conversation amongst payers about payment. Those are individual commercial decisions, and they will always remain so. So a reminder that that's not a conversation we can bring into the room. Does that make sense? Any Questions? Great. So I'm going to quickly touch on where we're starting from because we're not starting from scratch. Folks will be relieved to know. It's a heavy enough lift to adapt what is already out there and what already exists without starting afresh every time we do this. So there are a number of sources that we can draw on in terms of work that's out there, work from other states, things that many of you are probably involved in around BPCI, so bundled payments that CMS is driving. There are a number of groupers, so Prometheus and others that are out there in the public domain, and we do draw on those as we create our definitions. If we just flip to the next page, just to give a sense, because we field many questions from folks who say, why don't we just use Prometheus or use something as it is? And part of the reason that we don't just use them is exactly to have the conversation I flagged earlier, where we want to open the black box and we want to work out what needs to be tailored for Ohio's practice patterns, for Ohio's populations, for Ohio's providers. So a little bit different from a DRG, the intent is not just to take something that exists and roll it out. The intent is to work with you all to design something that you think makes sense and that is aligned with the way that you practice here in the state of Ohio. So some things that make sense to build on, which are on the left-hand side, I think I just covered most of these, and some things where we want to tailor. Okay, can we flip to the next page? I'm going to spend a few minutes on this page because this is really where we talk about what tailoring truly, truly means. So before we had excellent questions in the opening around thresholds and whether or not they're relative or absolute or how you define value. And before we even begin to have that conversation, there are a number of kind of foundational questions that we need to ask in creating these episodes. And these are the questions that we're going to ask as we walk through these 3 meetings of each advisory group. Now, I'd like to highlight that getting to the answers to these questions becomes a highly iterative process. So it's highly unlikely that at the end of meeting 1, we will have answers that we've agreed, signed, sealed, and tied to the bow to any of these questions. What we'll do is we'll bring a whole bunch of data, be very hypothesis-driven in the approach. Otherwise, we'll never get through all of this stuff. So we're going to bring a whole bunch of data. We're going to walk through what we think the data tells us. We're going to gather opinions from folks and see where folks land. You're probably going to have questions or additional ways you want to query the data, additional things you want to look at before you're comfortable. And so the process allows us to do that. We'll come back to all of these questions more than once. So it's not like there won't be a single opportunity to input and then we're done. So the first meeting tackles all of the really foundational questions. And we're going to walk through an example episode for asthma in just a few minutes so you can see the outputs of last year's clinical advisory group so you can see what these actually look like in practice. In the first one, we're going to tackle the patient journey. So what is the care pathway? And it's at a relatively high level. We want to make sure that we're all agreed that these are the kinds of things that typically happen to an average patient or a non-complex patient as they move through this care pathway. And we do that so that we can identify sources of value. And by sources of value, we mean areas for improvement. So areas in the pathway where the pathway frequently breaks down, leading to quality gaps or cost gaps, because those are what the episodes hope to address. So we'll tackle that first. That has to be the foundation for any further work that we do in the episode. There's then three data-driven things we're going to do in meeting 1. The first is the base definition. So what are we talking about? And you'll see when we get into asthma what we mean. So are we talking about just the inpatient stay? Are we talking about the ER visit? Are we talking about the primary care visit? Are we talking about including drugs or not including drugs? Devices, SNFs, so what's in and what's out, which, we'll get into it in more detail in meeting 2, but we want to get to a base definition for it in meeting 1 because that will allow us to drive the data that we need for the second meeting and third. We're going to walk through the triggers. So by triggers, we mean how do we know there was an episode? Remember, this is a retrospective reconciliation, so payers need some way when they look back to know that an episode has occurred. These look different for different episodes, so we'll try to get very early to can we agree on what we can see in the coding that lets us know that an episode has happened. And then we're going to talk about the principal accountable provider. So which provider is best positioned to do this? We have some hypotheses. We probably won't land this one in the first meeting, but we'll talk through, how we've come to the hypotheses that we've come to, and then we'll come back to the question. Effectively, we're asking who is able to influence up and down the value chain. Okay, in the second meeting, we're going to go super deep on two things. So inclusions and exclusions, so which services are actually part of the episode. And we'll take a look at this when we get into the asthma episode. This tends to be at the level of which codes are in and which codes are out. We spend a lot of time on services included, excluded, and risk adjustment because we're trying to make an apples-to-apples comparison. So you'll see when we walk through the asthma episode, the intent is to create a fair playing field. So as Director Moody highlighted, the state's intent is to create an environment where everybody can succeed. So it's possible for everybody to move to the right through a series of payment definitions. To support that or create that, our task is to make sure that we create a level playing field in terms of when we create those charts, we're comparing like for like. So to do that, we go through a series of steps. One is being clear on the services that are included, including the duration of the episode. The kind of questions we ask there are, how many days before and how many days after the triggering event count as part of this episode of care. What specific codes are in or out, which I think I just described. And then we spend a series of a pretty substantial amount of time, actually, on both exclusions and risk adjustment. So what we do is, based on the base definition that we've come up with in meeting one, we can create an early version for Medicaid of the chart that Director Moody showed, lining up all the providers anonymously. And then we make a series of adjustments to that chart. So one, there's a series of just straightforward exclusions that we make. So episodes that just get excluded or kicked out for either business reasons or clinical reasons, and we'll look at the detail of that in just a few minutes. We then take out some costs in each episode, or cost for each provider for things like med ed or capital, things like that we cost normalize to make sure we're making an apples-for-apples comparison. And then finally, we do a risk adjustment, which aims at, it's a little bit different from the way you might normally think about risk adjustment. We'll look at it in detail in the episode, but it aims to make sure that the practices, one of the kind of criticisms or comments that we often get when people first see that chart is that the folks on the left have the riskiest panels. And we'll look at whether or not that's proved true in the context of the asthma example, but the idea is to make sure that we're not just punishing people on the left for having risky panels. Particularly Medicaid wants physicians, doctors, and hospitals to treat the riskiest, most difficult, complex patients. So we absolutely don't want to create any wrong incentives there, and our risk adjustment aims to address that. And then finally, in meeting 3, we're going to look at quality metrics. The other thing that we'll look at in meeting 3 is we'll come back to a bunch of the decisions, as I said, in the iterative process from earlier meetings. So that's the outline of both how the CAGs work in terms of how we want to work together and how we want to interact together and what we're planning to cover. The next page has dates. Hopefully you guys have all of these already, and they're not news. We will create a dial-in because we do appreciate people's time in whatever format we can have it. That said, the conversation, these are highly collaborative conversations, and it is just easier in person. It's just hard to be on the phone, is our experience. I'm going to pause there and see if we have any questions before we do our last order of business, which is diving into asthma. Oh, there was one down here.
When you're talking about how you're tailoring your episodes and looking at this, I heard nothing about patients and patient incentives. The descriptor you used is entirely more of a parent-child relationship than it is working with the patient directly. And if there's no incentive for the patient to, say, use the primary care office instead of the emergency room, a lot of this is just going to be verbalization without a whole lot of final action. Can you comment on patient incentives?
Sure. I'm happy to give a brief comment, and then perhaps you want to comment on the state's perspective. So Director Moody highlighted there are a number of models that are docking together, so episodes and enhanced primary care. Patient incentives, I think, become a very important part, in fact, fundamental pillar of the enhanced primary care definitions. For the episodes, it is effectively just a technical reconciliation of costs. And so I think that we would see it as there's no intent here to drive how individual providers practice medicine, how they engage with patients, how they get to high-quality care that costs less. And so I think that's at the level of, these are designed to be levers that a payer can pull to help providers, to reward providers for doing the right thing, including working with patients in different ways. So if you had a...
Yeah, and I mean, this is going to keep coming up because the notion of patient engagement and personal responsibility, and it can spin out a whole lot of different ways. Just to take one step back in terms of the administration's view on our role as it relates to that generally, it was interesting. When we first came in, the governor had this view that we only had 4 years because he really believed the decisions we were going to have to make in that period of time would make it probably not likely for him to get elected again. So everything we did was on a 4-year horizon, and we had some skepticism that we could aggressively intervene in patient behavior from the government view in a way to really make a difference. So the way we saw to connect those dots the most directly was to use the money we have to go for a system of care that is known as engaging patients in the right way, and that's what led us to patient-centered medical home as an area of focus. So here we are working on episodes. We haven't yet brought patient-centered medical home as a statewide initiative online, but that's really the goal there, that we are getting at a better version of patient engagement that then positively interacts when these episodes occur. At the same time, we don't want to ignore that in the design of the episode. So if there are things to be done, and this is, for example, a source of value, there are certain things that the most important thing is not the surgery, it's the rehab, or it's the connection back to primary care. Why not make that a quality measure in a way that if you're not reconnecting that person or engaging them in a particular way, then you're not eligible for the gain sharing. So there are ways we can be somewhat explicit in making that tie. So totally agree it's important, but also are practical in our view of how can we use the money we have to change the structure of the system to then drive better engagement. Yeah.
Maybe this is covered under quality, but one of the things I wonder about is utilization. One of the best values is an episode that never occurs. So how do we take that into account?
Yeah, absolutely. And the way, when I hear the governor talk about this, the way he says it is, look, in an ideal world, on the Enhanced Primary Care side, if your practice is holding down the total cost of care, that's what you should gain share on. And not just the cost within your practice, but the total cost of care. Did you avoid an unnecessary hospital visit? Well, that value should accrue to a financial reward back to the primary care that achieved that. So a key part of the patient-centered medical home financial design piece is gain sharing back on total cost of care. So absolutely. And it'd be great if that's all we had to do. But then when something goes wrong, you're over here on the episode. So then you're in that environment. But yeah, totally agree. And that's why we would not have done one without the other. Because I think it misses how that has to fit together. Yes.
So you're, right now, obviously we'll focus on quality and laying out this clinical advisory groups, removing the cost issue, which is wonderful. Ultimately, I like the comment about patient and family accountability and having some responsibility in the game. And then, of course, the third piece of that is the health insurance company also. So ultimately, is that kind of part of the grander design? Are we going to look at those two and make sure that everyone is handling this in an efficient way and not contributing to the cost issue?
Yeah, so I mean, we always have all of those objectives, and we have different levers ourselves to get at it. Particularly with Medicaid managed care plans, we have some really powerful levers. But I'm not sure I know exactly what you're talking about, but I'm guessing it relates to kind of our willingness to take a regulatory approach on some of these things on the insurance side. And I think of this as a real education for us, where we're learning some things about the insurance side that we might be willing to take on. Transparency is a good example. What does transparency mean? You know, if you just kind of say, we're just going to require price and quality transparency, you can really get that wrong. But after having gone through this episode work, I think we're starting as a team to form an opinion around certain aspects of price and quality transparency that we might want to insist on, from plans back to providers, or in some cases from providers to folks who use their services. So that's an area where we might start thinking about how to take a more more of a role and try to sort that out. But we're on this side of it, not that side of it. I think right now we're going to, stay focused.
Thank you.
But it is, hopefully you all will enjoy the process as much as I have in terms of constantly learning how little I actually know about the system. You know, I mean, we had some fascinating conversations with clinicians in the last week, where little things like surgeons not being aware that hospitals had different DRGs. There was kind of an assumption that Medicaid just paid the same price to hospitals, and not realizing that the price of the hospital they were in could be drastically different from one hospital to the other. Just little details like that that constantly come up when we get into the details. Yeah.
That's another thing as a pediatrician, and my bread and butter is obviously URI, depending on how that conversation goes. We're also, if you think about it, building practices that you can redesign how they're doing work. You know, when we're looking at how to agree on that will really impact whether or not they can use it. I mean, those are costs down the road that we will pay, you know, probably up front, but may have longer term implications. So I don't know that we can actually calculate that. Those are the things that are probably out there.
Yeah, and that's where this really starts running. I mean, I always think of it in terms of a little bit of an aside, but like health information technology. You know, we can, as a regulatory matter, say everybody should have an EHR. You know, so you get it, and now you got your meaningful use payment. But did you really change your business practice to get the real value out of it? There's no financial incentive to do that, really. But if we're able to shift kind of the market demand to value comes from being able to see more things about who you're serving in a way that you really do have to access the potential of that EHR, that's where these things start working together. And we're trying to avoid the just do it because it's the right thing version, and instead trying to kind of reset the market in a way that it just naturally rewards the things in the direction that folks want to practice. Instead of swimming upstream, the financial reward should be rewarding value. So, but you all agree with that. So let's do asthma.
Great, thank you. Okay, so I'm going to hand to my colleague Josh, who's just sat across from me, to walk through the detailed asthma example. I will say as a preface, please stop and ask questions at any point. So it's a great privilege for our second round to be able to start with the detailed Ohio example. We weren't able to do this last time, so it's terrific that we can show you what it looks like here in Ohio with launched reports. Please do pause us to ask questions when we go.
So hi everyone. Like Cara said at the beginning, it's really an honor to be here talking with all of you. I was able to participate in many of the Wave 1 advisory groups, and it was inspiring to see the level of care and engagement that people took in those conversations. And I'm really looking forward to Wave 2 starting next week. The slides that follow here come directly from those conversations about a year ago, specifically around asthma. So I'm going to walk through the finalized patient journey that we settled on, sources of value, and then how we actually got to the final provider comparisons that actually were the result of that process. So you see on this page, this is what we're going to try. This is an example of what we're going to try and create for every episode that we engage with. A high-level patient journey that we can start building the episode around. In this case, in asthma, we have the onset of symptoms. We have the patient presenting either initially to a doctor or at an ED or even being directly admitted. And then we also continue that on beyond just that initial incident to the follow-up care and a window to capture any potential repeat exacerbations or readmissions. Now, after we've defined that, kind of the typical course of asthma treatment for an acute exacerbation, on the next slide, we attempt to identify with the group where there are sources of value that, given the right incentives, we could actually see improved patient care and reduced unnecessary expense within the system. The places that we identified for asthma are listed here, but some of the big ones, we talked about reducing avoidable visits to begin with. That's really going to be captured by the medical homes. But in terms of episodes, appropriate medication, reducing inpatient admissions, where we see a great degree of variability in what the criteria for admission was for an asthma exacerbation, appropriate length of stay and treatment within those admissions, and then appropriate follow-up care, connecting the patient with the right resources, making sure that they filled any necessary medications before leaving the hospital, and had a care plan to reduce the chance that they come back in to the ED within the next 20 to 30 days. So after we've identified those sources of value, we then move on to figuring out how we're going to capture that episode and capture those sources of value using just the fee-for-service claims data that you are already submitting, that providers are already submitting for the care that's provided. And my colleague Cara was already walked through these. These are going to be divided between the 3 clinical advisory group meetings, and we'll tackle them each in succession, so I won't dive into them here. But over the next couple of pages, and again, I'm not going to get into this detail, but this is a great takeaway if you want some fun bedtime reading tonight. The decisions that we actually came to for the asthma exacerbation, the codes that we decided to trigger on, including a range of codes that we thought would only define an asthma exacerbation if they were present in conjunction with other evidence of asthma. The duration of the episode window, the claims that are included, which are actually long lists of diagnoses, that care for those diagnoses should be included, procedures, and medications. What the principal accountable provider was. In this case, we decided it would be the facility, since it was an acute episode and there wasn't a lot of control over the patient coming in. The facility was really guiding a lot of that care. Quality metrics, in this case, the primary ones we identified were follow-up visits and making sure that there was a filled asthma controller medication prescription. But we also identified a longer list of quality metrics that we might not necessarily require for gain sharing, but we thought it was important and very helpful for providers to have at their fingertips. To know, for instance, what percentage of their episodes were having a repeat acute exacerbation within 30 days, what percentage of their episodes were occurring in which settings, what their utilization of imaging was, what percentage of asthma episodes were actually requiring that, and where their percentage, compared to their peers, and getting a little bit of a sense of whether they were in line and that was appropriate, whether they might want to reconsider their current treatment patterns. So finally, as we talked about, we also identified a set of risk factors that impact spend in episodes and would be outside the control of the provider. And the idea for risk adjustment is that providers really should be responsible for variation that they control, and anywhere that we can identify other sources of variation within the episode, in terms of demographics, in terms of pre-existing comorbidities, we want to remove that variation before comparing providers to each other. Certainly.
I apologize. And I know you're sitting right there, but I'm going to talk louder so other people can hear. And I haven't read the details, so I apologize. This information may be in here already. So let's say I'm going to talk about primary care because that's what I'm in. So I get a phone call from a family of a known asthmatic of mine. I know that they're wheezing significantly over the phone. Let's say I see him in my office. I know that it's bad. I send him to the ER. Is the primary care physician responsible for the ultimate cost of that care? Because what I fear is that if that's true, then people are in primary care may start to say, oh, we'll go to the ER rather than us handle it here. Does that make sense?
That makes complete sense, and it's a great question, and it's exactly the sort of conversation we're going to be having throughout the clinical advisory groups for all of these episodes. To answer specifically for asthma, we decided to make this an episode that's specifically focused on acute cases, so it begins once the patient presents in the ED or is admitted. So it is always going to be the facility that the patient presents that's responsible for. One of the main reasons is exactly that. We do not want to provide that sort of disincentive by accident.
Question. Looking at the previous chart, the quality metrics really are key to who's going to get in, gain share and not. In my view, the clinical quality is going to be important, and I was happy to see that there were quality metrics attached to that. These quality metrics, the two you have listed here, was there consideration? 30 days seems like setting the bar pretty low for a follow-up visit for an acute asthma attack. Was there discussion making that? I guess my point is that we don't want, or I would not want, to have the gain share dependent just on financial metrics. The way that what I understood we were going to get away from that and make it clinical quality was to have quality metrics you have to make. And if we set the bar too low, then you're not really doing that. I mean, I look at these quality metrics and think that the bar is pretty low.
So, two thoughts. One, yes, lots of discussion, and actually for each of the episodes we're going to design together, there should be lots of discussion. So quality metrics is an area where absolutely we should have the debate around what is the high bar and what is the low bar. The other thought is that the bar is not fully defined here, because I don't think part of the devil on 30 days is half the question on whether it's a low bar and a high bar. The other half is what is the percentage, right? So what is the percent of half?
Well, I guess the other question is does the facility really have the ability to determine that, since the follow-up is going to be with the PCP, and the responsible provider here is the facility?
Correct. And so part of the
these are the discussions we're going to have.
These are absolutely the discussions we're going to have.
Okay.
Part of the philosophical underpinning of the episode of Courage is that it is approach-based and team-based care. So absolutely, there are huge challenges, regardless of in each episode whether the facility is a PAP or the physician is a PAP or somebody else is a PAP. There are enormous challenges in saying how do we ensure that accountable provider or quarterback is able to influence up and down the value chain, right? I mean, that's absolutely right, and we would that's a very healthy debate. But the philosophy to bear in mind is that we are hoping that people can influence up and down, because otherwise there's not a lot of team-to-team care.
Thank you.
Quick comment on why ICD-9 and not ICD-10.
Oh, I was waiting for that one. Thank you for asking.
I did want to disappoint you.
There's an optimist in every crowd after that.
we have to pull data the way we have it, which is ICD-9. So we have to show you data. We would love to do that interpretation and switching over.
So a year from today it will be ICD-10?
Well, we have to pull it in ICD-9, which is what we have now.
But a year from now, it won't be
It will be
ICD-10.
ICD-10 in the future. So we haven't arrived to that. What you'll be getting and what you'll be reviewing is ICD-9. And then we'll have to do this interpretation.
Oh, you mean for our work?
For our work right
Yes,
now. It's gonna have to be
understood.
ICD-9.
Okay.
It's retrospective. Right.
How are you able to capture the readmission? Are there readmission codes? How are you able to capture they got readmitted within 30 days?
Certainly. So a readmission for our context is defined by any hospitalization within those 30 days that meets we use the BPCI criteria for readmission that is most relevant to that episode. And BPCI has defined a DRG-based list of essentially, emergent care that won't be relevant for a given type of bundled payments. So these are things like severe trauma or certain transplants, things that clearly aren't going to be related to an asthma attack. If we see those DRGs appearing, that's not going to be a readmission.
We're going to put them all out in front of you. So absolutely no black boxes. So for readmission with this group, we sat somewhere in I think our second or third group with a list of codes that would count and had a very healthy debate. What in here, by the way, people took it away as well and gave us feedback by email. So what in here do you not consider to be a readmission for asthma? And let's, that's actually part of the fun of the process. And one thing that's interesting, and I hope we see play out as well in these groups, clinicians don't always agree. You guys have different opinions on what counts and doesn't count, and that was some of the most interesting and dynamic part of the meeting, right?
So I will press ahead because I know we are running a little bit short on time. There are a list of exclusions there that you're welcome to review. But I just want to back through or walk through over the next few slides how we reach our comparisons between providers. Because if you line up providers right now, after implementing all of those definitions around what is an episode, if we look at the average cost of these episodes across these providers, you'll see a curve like this. But this curve includes a lot of sources of variation. Some of it is driven by clinical decisions that the provider has control over. Some of it is not. And we want to get rid of that second category before we make any comparisons. So starting with this curve, we then remove a set of exclusions. So these are episodes where there is evidence of either, from a business side, incomplete information, or some sort of claims irregularities. On a clinical side, evidence of conditions that will make the course of care for that particular episode so divergent and unique or extreme that it wouldn't be fair to compare to episodes without that condition. So that's things like, extended ICU stays, ESRD, HIV, etc. So when we move on to the next slide, you'll see the impact of that. That a lot of this spend actually ends up being from things that are maybe not actually the asthma episode. These might be people who are actually in for cancer treatment and also have asthma. So we've gotten rid of them to make for fairer comparisons. And all of a sudden, that ordering has changed. The person who was on the provider was on the far left, looked very expensive before, now may just have had a lot of highly comorbid patients. We then take another step, and the decision has been made that medical education and capital expenditure spend is not going to be relevant for episodes. So on inpatient claims, part of the cost of an inpatient claim would be med ed and CapEx expenses. Those are just going to be removed from claims and spend and not ever be considered relevant to the episode. So we remove those, and the curve doesn't change that much because asthma only has a limited number of inpatient admissions. But in other episodes, that curve would change much more. The final step is actual risk adjustment and the application of high-cost outliers, which is applied on risk-adjusted overall spend. And this is a list of the risk factors that we identified through a conversation with clinical advisory groups, plus some significant data mining to support that conversation. But it's all a back and forth. Identify factors that both clearly have clinical reasons for impacting episode spend, clear clinical pathways for changing the course of care, but also when we look at the data, that there is a correlation between each one of these factors and increased spend on these episodes. So we then, just for the sake of comparison, and remember we're just talking about comparisons here, we basically factor all of these things out. So we try and compare, as Director Moody said at the beginning, providers to each other as if those providers had had the same basic, typical healthy patient panel, and how they would have performed if they all had that same panel. And if we look at the final slide, here, that's where we end up. And this is just for comparison's sake, so you can see that the ordering has really changed pretty dramatically once you account for these risk factors. And the normalization of CapEx and Med-Ed, and the removal of those exclusions. Yes. So if we go on to the next, it's not flat. So if we go on to the next slide, we've reordered this, and you can see that there is actually almost probably a 3x difference from one side to another after you've performed all of these adjustments. And this is an important slide because at the top you see the curve now, only valid episodes, all the exclusions removed, all the risk adjustment performed. But at the bottom, that's just the degree of risk adjustment, or rather the degree of riskiness that each patient, each provider's panel had, with higher bars being more risky panels and lower bars being less risky panels. What you can see here is, like I said, there is no trend. Once we perform all of this, the providers on the far left, those who are doing significantly worse, do not have riskier patient populations than the providers on the far right. In fact, one of the providers after risk adjustment, with the riskiest population that we've been able to identify, is in the top quartile of performing providers. Now, what actually drives this? If we go on to the next slide, we can see that one of the major things, one of the things that was identified in the clinical advisory group is a lot of variability, even after risk adjustment, in the amount, in the criteria for inpatient admissions. It's a large driver. Also, how often patients were coming in for repeat exacerbations, which turned out to be very expensive. So those were two. There were also a number of other around medications and those sorts of things. But we were able to identify some significant behavioral differences in the providers who are on the far left side of the graph and far right side. So what does this all mean? Where does this all get us? I get this here, which is an example of some of the provider reports that have actually already started going out and are accessible to providers who have asthma, COPD, perinatal TJR, or PCI episodes.
And we'd like to flag, we have some sample copies available of versions of these reports to use illustrative providers to give you an idea of exactly the types of material that were delivered to providers as part of this asthma exacerbation episode. We have examples for a few of the different episodes that are live. I'd be happy to share those on the way out.
Excellent. So as you can see here, on the top right, you have the curve that we just looked at, and this specific provider's position in that curve, where they were comparing to their peers simply on this adjusted cost. Also, their overall stats for quality metrics, how many of their episodes were actually they had and which were included, And there are a couple of more pages behind here which Mike can provide examples of, not in this deck, that get into more depth of where that provider falls along each of these metrics compared to their peers.
And not just some additional detail, but a lot of additional detail. So able to see all of the claims from all of the various sources related to the episode, regardless of provider, all assembled by individual. So some of these reports are actually many pages.
And it,
Just prior to the meetings, will we get a list of the other people on the clinical advisory group with us and what their titles are?
Yes.
Can we?
Yes. In fact, we can send that.
Question. I'm trying to remember, I assume it was true with the other perinatal and joint with the other episodes, that the slide about the correlation with the cost and the level of risk, when you take that out, I assume that held up for the other episodes. And I just think it's important for everybody to note to not go out and say there's no correlation between the cost of the episode and the level of risk. It's once you take out all those episodes with some risk. It could be that if you just added a few back in, you would start to see a correlation.
yeah, no, certainly. And prior to that, yes, if you looked at the original curve, the people on the providers on the far left often did have much riskier patient populations, which is why risk adjustment is so important.
Exactly.
Yeah, to me, the most important thing about that picture, the red picture is the test as kind of the referee of the process. It's the test that for what ended up being left in the episode, the risk adjustment seemed fair. That's the key. Because, yeah, all those other things have been already taken out. So for what's left, is it fair? That's the key. And in some cases, it ends up not like that. So it's an indication that there's something about the risk adjustment itself that needs to be worked. And we'll just keep working on it until that distribution is
Just asking a question about how confidential information can be sent out to other physicians, or no, we would rather that not happen.
well, you see your actual report.
Just even there.
The generic numbers are posted on the website.
Oh, good, yeah.
These are fake.
So they're all made up.
Yes, these are fake.
This one's made up. So
It's just even just the layout of it, 'cause it's already started.
yeah. Yeah, so you can see that in addition to the first page summary, there are some additional pages of still summarized information where there's a little more detail in the distribution code, and then a layout that shows relative position on some of the quality measures. All of this still rolled up. And then what you don't see here are the additional pages that have individual level claims data. So if you have an outlier, for example, on your chart, you can go in and look at the actual data to see what combination of cost variables added up to that high cost case. So you can start to actually get into some of the detail around what's driving the higher cost cases versus the lower cost cases.
There's latitude amongst the clinical advisory groups in terms of defining the episode. So, I look at GI and I look at colonoscopy and EGD, start thinking it's a pretty vague area. It's not a very well-defined event. And, for example, could you narrow that down to screening colonoscopy and that sort of thing? Is there any latitude based on that?
I'll give you an example of where this happened real time last time. So we started our PCI episode with the proposal that it would be a single episode, and our clinical advisors felt very strongly and had good reasons for saying we should split it into acute and non-acute PCI, which is one of the areas where I think I said earlier that we take some external definitions and then we work with our clinical groups to make them work for Ohio. That's very different from how other people have defined PCI. It made perfect sense in Ohio. The rationale from the clinical group was compelling, and that's what Dr. Applegate and Dr. Mindy decided to do. So, yes.
Yeah, and through the process, we tried to pick things in advance that will be relevant in terms of their volume across both commercial and government payers. But the last time we figured out, one thing that happened was by the time we got through it all, there was really a pretty small population in Medicaid to whom it applied. So we ended up making a decision to not attach payment incentives on a couple of the episodes in Medicaid because the volume was just too low. So one thing we'll be kind of mindful of is kind of definitions that get at what is kind of a meaningful episode. But if we're not able to do it, I'd rather cut it loose than, kind of make up something that's too broad.
Simple question. So this is a risk-adjusted average spend per episode. And given that provider is put on that graph, so the assumption is that provider's cases are also risk-adjusted, correct?
This is kind of an overall question, but it appears that in this case, the primary accountable entity seems to be the provider. And I get that there's a lot of things we can do to improve the value of healthcare to bring down the cost and also bring down mortality with patients, like some of the things you listed with follow-up and all that kind of stuff. But one of the things that you mentioned is, are they on the right medications and things? So those physician-independent variables, for example, for COPD, patients who can't afford controller substances, which if they could afford or if they had better insurance coverage, wouldn't keep ending up in the hospital. Like maybe improving the insurance coverage would be less of a cost for the system than having to take care of them every time they had the exacerbation. So is that being considered either incorporated into this or independently? I don't know.
So I think that's a terrific point. Again, it's exactly the conversation we should have. I mean, I think it's easier to have that conversation when we look at the specifics of an episode because it'll look different, right? So the question in perinatal looks different from the question in COPD. But it's precisely the conversation we should have in the room. And it might also be different. I mean, the state is best positioned to talk about Medicaid, and it might look different from Medicaid and commercial populations as well.
Right. It usually is. I'm just like, sometimes I feel like I'm doing everything I can, but then I'm like, now my hands are tied.
No, it's a terrific point.
Okay.
The only way I've been able to reconcile it is patient-centered medical home wrongly conceived, where I love the asthma example before, where, wait a second, if this had been handled the right way, they wouldn't have shown up at CED. Well, that decision point, if you're gain sharing based on total cost of care, it is actually better for that person to come into your practice instead of going into the facility, because that facility cost is going to count against you when total cost of care is calculated. So the notion of it needing to be as broadly conceived on the primary care side, but the episodes think of it the opposite, as narrowly defined so that kind of in this very specific case, maybe there's only one or two sources of value. You admit or you don't admit. And trying to isolate to that key decision where because people seem to make a different decision there, it has a real impact. So, and again, that runs counter to what I was just saying about it needs to be broad enough to be of a scale that's relevant, but for it to be really meaningful for what we're doing, we're really trying to define it as carefully and specifically as we can. So.
To that point, I saw as you were going through the asthma care path, there was a version 2 possible quality metrics that talked about it as presence of an asthma care path, which is really where the savings is. That's where this all needs to go. Now that's outside the episode and it's unrelated to claims data, and it's is that fair game? I mean, should we be thinking in that fashion? Because that's really the essence of where this all should go. And include it where we can. And
yeah, exactly. And many times, the despairing moments are when you get far enough into it to say, whoa, wait, we got it this far. But really the ideal version is to get it to here. The problem is we're all the way back here right now. And if you don't even have the data or you can't even see it, you can't even get to that next. So as we're getting to the next step, what's going to naturally happen in the process is you're already going to be looking ahead to the ideal way to do it. And we can't despair that we can't automatically build the ideal version. We have to at least start biasing the system to reward the right thing to do, so you're at least in a better position than the key.
That's going to come up in UTI.
Yeah.
Preventive aspects of UTI. URI are so all about prevention.
And we collect them. I mean, this was exactly, so that little box with the potential V2 quality metrics came exactly from a conversation like this. And it felt important, you know, they've landed on the memorialized version of the episodes. It's tracked because it felt important that we track them and we collect them and we say, okay, we want to do this when we can do it, whilst acknowledging that we can't do it today. So that, you know, they don't get lost, those thoughts.
So the process in my mind is we're measuring the outcome, and the outcome is the cost. So if we strip off the contribution, that you raised the question about what did the patient attribute that contributed to that cost, we're left with an outcome that's pure to the art of practicing. The process measures, like are we using a clinical pathway to achieve a good outcome, I don't know if we need to measure that if the outcome measure is pure. Because it adds an administrative burden that we have now. We have to check the mark that, yeah, we did a pathway, turn that in, and that pathway, I don't know if that has value because it's a check mark at the end of the day. It's how well we're deploying in the world and affecting the outcome.
One observation that I think is kind of setting Ohio apart in some of the national conversations is we try to be very pragmatic in what we can actually do. Sometimes that means saying, well, at least we have the claims data, let's just use that. Even if it's not getting at the whole picture, it's at least something we have now we can act on. And some of the things I've seen gone wrong are where there's kind of this attempt to do the bigger, better version, but then you realize you can't get what you need to have a quality measure, so then everything else falls apart. So it is this blend between kind of just doing the best with what we have and just to advance things. I'm getting sensitive on the time because I know we've already asked for a lot of new time. We would sit here all day long because this is some of the most interesting work we had as an administration. And at 2:30, I'm walking over to brief the governor on kind of where we are in this conversation. Because it is something that he's, for whatever reason, he is personally very interested in. You'll see that that's something that's kind of a good thing our administration is doing. So I just wanted to thank you again for your time. Generate as many questions in advance as you can think of and bring them with you to the next meeting because it's going to be very intensive and we want to get as much done in the room as we can. Call in if you need to, but what Kara said is exactly
questions about episodes. That is a great place to go and just spend a little bit of time poking around prior to these meetings.
One other note along those lines, if after experiencing this training session, you feel like it would be useful for other colleagues, well, if you go to that website, a link to a video webinar of this exact session will be posted. Feel free to share that link with colleagues who might be interested. If you want to invite them to the CAG as well, we'll be happy to hear from you.
And just so you know, for the first wave of episodes, the first 6 episodes that the state developed in partnership with the providers and plans, the first wave of reports actually went out in the month of March. So for those of you who work for larger systems or who have peers that might be simple handle provider of any of the first 6 episodes, kind of share this information with your colleagues and remind them that reports are currently available on the first round of episodes. It's a real report, not the made-up one.
Data.
Yes. And if you have any questions about that, feel free to contact any one of us.
And it's available.
Thank you all.
Each is provided